Okay, so I just did the other video for somebody that had requested feedback on how to study for um, the advanced pharmacology, advanced um, pathophysiology, and then I talked a little bit about studying for advanced psychopharmacology. So I'm coming on here to talk about the OSCEs because like OSCE and clinical. So like if you don't watch any other videos and you're like doing psych MP, like you need to be watching this video, um, so that like you can learn from my mistakes. So again, I want to just like put a clause out there. I'm ADHD. Okay, so if you know, you know. And so for those of us that are neurodivergent, we'll get like tons of emails. So to give you tons of emails to inform you and to communicate. And if you do not like pay attention really closely to those emails, you're going to miss some key things in there that you really need to know that can set you back on your clinical time. So let me just go ahead and say that first. So the very first thing is like, you're going to do all your hoops, right? Like some of you know from like other states, if we're in Texas, we do the Castle Branch and stuff, or like our nursing schools. It's awful. They use something else. That one actually wasn't too bad. I think the one that WGU used, they're pretty good. And they will like alert you if like you need a certain shots or whatever, right? So that you can get your clinical clearance. That includes like getting your preceptors. I've been asked many times, is it hard to find a preceptor? How do you find a preceptor? Honestly, I just used connections. My best friend used to work in a psych facility and she was like, let me go try and find somebody for you. You get really like, you get scrappy. You do whatever you need to do to like. And then I also teach at a different university. And so I like ended up knowing when I was doing clinical rotations with my students, I ended up meeting this psych nurse practitioner that went around in that area. And so he was like, hey, I have a friend and I can help you get somebody. So just like however you can find somebody. It's unfortunate that they don't find that for us. A lot of schools don't, and it's just difficult. Like, yeah. So the sooner you can start, the better. Start making connections with people. And I would advise probably not just like going in and maybe go in person. I don't really know. See if you can talk to somebody. Do whatever you got to do. Okay. Like do whatever you got to do so you can get that practice. So the thing about your clinical clearance is you will get clinically cleared and they will do a whole like orientation video with you and everything. Awesome. Great. Listen to the orientation video. Even if you don't make the video live, they still have the recording so you can listen to it and you listen to all the expectations, right? I listened to the video, right? But like, there's just a lot of pieces going on when you're gearing up for clinical. Something really important to know though is like, once you finish your first clinical, you have to get another clearance to start your second clinical. Like even if it's with the same preceptor. So you have 3 rounds of clinical rotations. The length depends on if you're part-time or full-time. I was part-time in the beginning, but I'm full-time for the last 2. So that's going to be like 215 hours, which is like not terrible. Okay. It really isn't. I've really, really enjoyed my clinical time. It's been amazing. But if you do not, you have to make sure that like once you're done with your first round of clinical, that means you pass your midterm OSCE and your final OSCE, and you do whatever if you have to do like these module things inside there. Make sure you get those done. Those are easy though. You can get those done fast. And then you put it into this file document folder that they especially have for you. And you just basically make sure like with all the other, when we're doing CPEs and stuff, like they'll have like a check off listing that we have to do an initial and sign and what date. So you'll still have that for your clinical rotation. So you do that, you do like your little assignments or whatever, like get in there to start doing practice questions and this, thing that they paid for to help you gear up for your boards. And the idea is that you're like kind of doing them quite consistently. I have not been. So I need to do that. But you do those, and then once you're done with that, your final OSCE, and you've done your midterm evaluation, which is a 3-way call between your preceptor, your professor, and you, and they're evaluating you in real time, what they think you're doing really great, what they think you need to work on, yada, yada, yada. Then they'll sign off on everything, your professor, and then you're done. So it's not like in other courses where you can have two like D348 and D349 assigned to you. And like normally, like if we don't like have to finish one course and go to the next. We could do both courses at the same time and have them going, okay? The idea is that like once you start a course that you're like gonna finish it, otherwise it's gonna be incomplete and roll over. Whereas if you don't start it, they can shift it down so it looks like it was not even ever attempted. So I went ahead and started D349, but I needed to do an OSCE redo. And your OSCE is basically like where you do a mock psych evaluation on a fake patient, and you have to basically diagnose them, determine if they need medication treatment, if they need any kind of like psychotherapy or whatever your interventions are. And so like they'll tell you from the very beginning, like nobody passes the first time. That pretty much everybody has to redo it. So don't feel one way or the other about that. Like just expect that you're going to have to redo a portion of it. So you'll do your first initial and then there will be a partial redo. That partial redo can be very like maybe you only miss like one or two sections. Like maybe you only miss, like if you're looking at this sheet, this is the sheet that they give you. And I wouldn't be too attached to it. Like once clinicals and stuff starts, you'll be able to download this. It'll be in your on your thing. But like maybe you miss elements of like the patient's social history. So you will have to do you'll have to do a redo with another person, and like you use Pantop or whatever the heck that thing is called, that video thing recorder, and you basically do that section over again with them. They won't reread the case study and stuff unless you really need them to. They won't do all that. But this is really important to know, okay? Depending on, and it's not the person that's like doing the recording with you. I forget what they're called. It's not them. It's the graders, right? The graders that are grading your interview. The very first OSCE I did, I had areas that I missed, but all I did was scheduled a partial redo, and I did that, and I just stated the things that I was just missing from the categories I was missing it from. I didn't redo the entire section, okay? Did that, passed, diagnosed the patient, felt really good about that, moved on to the final. I'm still waiting right now to get a green light on my redo. So I did my OSCE, my interview, and then I looked at the feedback and said I didn't pass. Okay, fine, kind of expected. Didn't pass. So I looked at the redo, scheduled that, and redid the sections that I was missing like I did with the first OSCE. Here's the thing. Some graders are really good at giving really precise feedback. Some are not. They'll be like, elements were missing. Or they'll tell you like one element that was missing, and you're like, okay, is that the only thing that was missing for you? Do I need to do a better job of assessing this? Do you think it was not this was not adequately assessed? Like, what was it? So, word of advice after talking to one of my professors, whom I love, she was just like, redo the section. There was literally one section that I was like, because when you do the video recording, it will actually script out your narrative, like the talking back and forth. And so like you can have your entire conversation back and forth with the fake patient time-stamped. And so I was like, I literally transcribed everything. Like I literally time-stamped every question that I needed to ask for the medical review systems and mental review systems. Psychiatric review systems. I didn't miss anything. But the second video, she said that I didn't restate a recap of what I had assessed. And I was like, okay. So the second redo that I did, I just stated the recap. I was like, okay, patient denies blah, 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 blah. Does that all seem right to the patient? Yes. Okay. That was a no-go. That particular graded wanted you to redo that entire section. So word of advice, if you're missing something from a section, just redo the entire section because you don't know what grader you're going to have. So just if you're missing elements of social history, just redo social history. One step further, this is my advice. So moving forward with other OSCEs, and honestly, I actually like their PMHNP initial psychiatric evaluation sheet. I actually like it. It's really thorough. It's really good. So my word of advice is when you get this sheet and you have all the different categories and stuff, go ahead and just write down the questions that you need to ask for those specific items. Like if you're trying to assess if a patient has like delusions or hallucinations, and like you get confused between delusion and hallucinations, like just because like real talk, okay? Just and not even getting confused between like delusions and hallucinations. Delusions being like false beliefs and stuff, and hallucinations being more like you're seeing something that's not there, or hearing something, auditory visual hallucinations, right? And again, I'm speaking to some people because not all of us were psych nurses, okay? So I'm speaking to like a broader audience here. You can just like in this thing, just write a little note in there of like how you want to ask that question. When you get all of the things, like when you do WGU Connect, because you will, and they're going to have you like go there so you can do all the orientation and the checklist stuff and you can see everything. They have really, really good things in there, like really good descriptors of like how to assess for appearance, how to use certain language to like say what you want to say, right? Because what I find even when I'm in clinical is like the hardest part is like formulating a language that is templatey but descriptive enough to make sure that I'm relaying the message that I need to relay about the patient with regard to the patient. And so that can be challenging because you're not in your nursing brain anymore. You're now a provider, so you're in provider brain. So I find that's really helpful. They have documents they're going to tell you to print out and put those in a folder and take those to clinical with you. Those are helpful. There's even one that they have that a student made, which was a very complete like PMHNP initial psychiatric evaluation with all the questions to ask in each category. I really like that one, but you can still miss things using that one, even though it's very thorough and the print is like really, really tiny, but it's a very good one. Whoever did it, bless them. I would say if you want to take that document and infuse the questions into this, it's going to be really hard for you to miss anything because this is literally the thing that we're turning in. So that's the biggest thing is like there might be elements on the one that the student had that might be missing like on there, whether it's like legal history or, you know, have they traveled recently? What was it like for them growing up? Those kind of things. So my word of advice is like, just go off the dang template that they give you, okay? Put your questions in there, how you want to ask those questions. So again, the two big takeaways from this video are, number one, you need a clearance for, when you get that clearance is for clinical number one. Before clinical number two, you have to have finished all of those elements, OSCE 1, OSCE 2, and your CPE checklist thing with the modules and everything like that, okay? Doesn't take too long, just need to get it done. And then like your practice quiz thing that you'll put in your file folder. This probably doesn't make any sense. It will once you like look at it and you see it and you're like, oh, okay, I know what she's talking about, okay? Once that's done, then you will get clinical clearance number two. If you don't get clinical clearance number two, you cannot start your next clinical rotation. Where it got kind of confusing for me is like, you still need one, even though my preceptor, there's 3 clinicals, I only have 2 preceptors. So I'm doing 1.5, okay? So I'm thinking, well, I don't know why I need another clinical clearance, but it's a whole new other clinical. So it has to start completely brand new. Where you're putting in all of your patient reports and everything, where you're putting in all of your stuff for, you know, your patients and stuff like that, D348 has to close out. It's going to close out and say it's completed, and D349 will initiate, because what ends up happening is even if you go to like, you're going to see my field experience or whatever you click on, that's where we go put in our forms for the patient interactions that we've had, or even like the days that we've done with our preceptor. Sometimes it will cross over into D347 because it's not complete and it will not show up as D348. You don't want that because your clinical time, guess what, doesn't count. And I completed already half of the complete hours. I completed 107.5 hours, actually a little bit more than that, with my preceptor for my second clinical, and none of those counted. So it pushed me back. It pushed my graduation date back by a month. It's not the end of the world. It sucks, but it's not the end of the world. I'm just letting you know, like, learn from my mistake. Make sure that you really complete that. Also, don't procrastinate on it. Just do it. There are no limitations on how many times you redo your OSCE. Yeah, fun fact. So I thought like, oh, you know, like if you don't pass your first exam for like pharmacology or whatever, right, we can, you know, we talk with our professor and then we schedule the second retake. And then if you don't pass that one, then you have like, I think 2 or 3 times within your program where you can lobby to take do a third attempt. Okay. And I think, and maybe third and fourth or something costs you money, costs like $25 or something. I don't remember. But anyways, with your OSCE, that's not the same thing. There's unlimited attempts. You just have to complete it. So again, make sure you're very thorough. I even went as far to say, and we'll see if it passes, because look, sis doesn't even know what else to ask at this point. Like, I didn't ask everything. But I literally was like, social history. We're going to go over your social history now. Do I say that in an interview with a real patient? No, that's weird. I don't say that. That's random. Okay. I don't title everything before I talk about it. But I did it for the sake of the OSCE. So there was like no disputing. Again, your transcript is live and in person, like on that video. You're going to record. You need to record. And they're going to record. Why do I say that? Because twice it's already happened to me where the person that was like doing the interview, the fake patient that was running the simulation, their audio was not working. And I had to now reschedule 2 times again to do an appointment. And appointments are they're not like super hard to get, but sometimes they can be. There's like, usually they're taken up pretty quickly. It's like if you need to do another retake, it's going to probably take you another 3-4 days out before you can do the next one. That's what I mean. Okay. So just really kind of make sure you have your ducks in a row, make sure your volume is working, make sure their volume is working. Literally after they're done with the video recording, they're going to drop it to you in your email. Click on it, listen to it, make sure that you can hear yourself and them. And if you don't, email the OSCE group, which is going to be in your emails, OSCE group, that's like all of them, and tell them, be like, hey, I was literally just online. I did my OSCE. There's no volume. There's no, I can hear myself, but I can't hear the person facilitating, or I can't hear myself, but I can hear the person facilitating. So sometimes it might be for me, it was a technical error on their part, both times. For me, my audio was working just fine. Okay. There's also some like annoying things that happen with the audio when you're using CareSpan Clinic, which is what we use, and Pantop, okay, or Pantop, however you say it. Sometimes when you open, and I don't know why this happens, and maybe it's like how the audio is being taken over, but sometimes I think you open CareSpan first and then you go open the Pantop video to go record, it makes CareSpan audio not work. I know, it's weird. It's annoying. Like 2026, somebody figure it out, okay? So do it the other way around. Open Pantop first, then do CareSpan Clinic, whatever the heck it's called. So make sure you do that. Make sure you can also ask like whatever questions you need to ask. Be like, are there any vital signs that you have for me before I get started that I need to know? Or should I be asking that in the interview? I do that right there and then. Lastly, the other thing I'll tell you about right now is just like prep for your OSCE. Prepping for your OSCE, because they're going to throw a situation out at you based on your last name, okay? You're not going to know what the scenario is. You're going in blind. You can do this. You can do it, okay? You're going in blind, and I'm very well aware that this is our DSM book, and I'm very well aware. These are the labels that I need to put on. I've had for like weeks and haven't done it. I'm very well aware that there are a lot of diagnoses in here, okay? They're not going to give you like the hardest of the hard diagnosis. But I assume they're going to get a little bit more challenging as you go on. I have the world's best preceptor right now, and she's been giving me cases that are really hard just to challenge me, and I have been able to rise to the occasion, and I would say like 85 to 90% of the time, so I'm really proud of myself. But have like the top 20 most diagnosis, okay? And then like the top like 40 medications and classes and side effects. Have it for like what to do if a patient has depression and PTSD, what to do if a patient is having nightmares. Have dose ranges on there. You're allowed to have papers, like packets and stuff that you've created, and I will have that. I will have like a little protocol on like what to do if I'm getting a patient that has a drug addiction, or if I'm getting a patient that has, schizophrenia, or one that has bipolar. I have like a little step-by-step guide, knowing, make sure you know things like in order to, that when you're diagnosing with somebody like with major depressive disorder, that you understand that like you've assessed thoroughly for bipolar, right? Because we don't want to send them into mania. So just things like that. You can have like little packets, and I will have a whole bunch of little packets around me that I have labeled so that I can just pull them quickly. I'll have my DSM-5, and then I have my prescriber's guide next to me. And I legitimately, the very first OSCE I did, I said one medication. I was like, that doesn't seem like the right medication. I just paused. I said, hold on just a second. And thank God, because I like went to it and I was like, I think it's this medication. And I just flipped through it and I saw that medication, saw the dose, and I was like, this is the one that I want to give. So just make sure that you have it there. It would be beneficial probably to tab that one up too at some point. You know, tabbing takes forever, but it would be probably beneficial to have that. But just have like, even ChatGPT can just make you a list of top 20 meds with clinical pearls, starting doses and ranges, where they're contraindicated, you know, if they're prolonged QT elongation for certain medications, or they're not good in the elderly population, or, you know, they have, you know, side effects of weight gain or whatever it is, okay? It's good to just like have those that set on hand, that you can go to first, so you kind of have a plan. Also, understanding that like for your diagnostic criteria, like if you're ordering labs and stuff like that, that's completely fine. Make sure you say that in your OSCE that you're ordering certain labs. And also make sure that you understand whatever the like assessments are. Just like have a list of them. They actually provide one for you through WGU with the WGU Connect thing. Make sure you have like a list of, you know, the PHQ-9 or the CSSRS, or like whatever the different assessments are, and like, you know, the ADOS, whatever they're associated with, and just like having that there. You don't have to do those assessments in the OSCE. You don't have to do them in the OSCE. I mean, like, let me tell you, maybe you do them in the, I haven't done them in the OSCE. Like, they would take a minute. And like my initial interview is already like long, right? Like that's a lot of information for us to get through. An initial interview with just like a random patient takes a good nurse practitioner 40 minutes. A brand new one takes them maybe like an hour and a half. So you can imagine that it's kind of a lot. So having those things on hand is like super critical and super important. You are not going to just like walk into your OSCE. I don't even care if you've been a psych nurse. You're not a psych nurse anymore. You're a provider, and you're going to walk in there with material like you were going to diagnose somebody. In real life, do you diagnose somebody right away? Yeah, I mean, we do, maybe sometimes, you know, you do. I would say like, yeah, generally you do diagnose somebody. I don't know that we always do it like on the spot. Sometimes we have like a CPE, the patient goes away. I'm sorry, I keep saying CPE, and I don't know if that's from my clinical rotation or whatever that label's coming from. You do your initial assessment and with your patient, and I mean, sometimes we do like right there and then with the patient be like, I think this is major depressive disorder, or I'm thinking bipolar, and I'm thinking we might try this. And, you know, you go through the whole thing and educating them and explaining to them and see how they feel about that as well. But sometimes you don't. And as my preceptor likes to say, you noodle on it. So sometimes you're noodling on it and you're kind of thinking, feeling it out. It's a little different for where I'm located right now because I'm outpatient, and we see a lot of the same patients over and over because they meet with us for med treatment for outpatient group therapy. So it's a little bit different than like you would experience in inpatient, which I've also done inpatient rounding as well. And in inpatient, you know, a lot of times it is like, yeah, of course you're diagnosing and we need to treat you because that's why we're here. So just keep those things in mind when you're doing your OSCE. If you have any questions, let me know. I know that was really long-winded, and I'm sorry if I lost half of you halfway through, but hopefully all of this information helps. If there's anything extra that you want, just let me know. I'm going to hopefully keep my comments open so that you can comment and like, subscribe. That way, hopefully you get notifications when I have another video up to let you know how I'm progressing. Okay? So have fun at clinicals.